Hello, everybody, and thank you very much for joining us today, Thursday, 4th of March, for our press briefing for an update on COVID-19 situation in the WHO European region. My name is Luba Negro. I'm part of the WHO Europe's communication team and will help with today's briefing moderation. Let me briefly introduce our panel. We have with us, as always, and thank you very much, Dr. Hans Kluge, WHO Regional Director for Europe. He's joined by Dr. Catherine Smallwood, Senior Emergency Officer at WHO Europe. We also have online with us Dr. Siddhartha Datta, Regional Advisor and Lead of the Vaccine Preventable Diseases and Immunization Program at WHO Europe. And we have Ms. Isabel Jordi Aguirre, WHO Europe's lead expert on gender and human rights. So we have an hour for the briefing, and we'll start with a short statement from Dr. Kluge. Dr. Kluge, the floor is yours.
Good morning, everyone. Last week, new cases of COVID-19 in Europe rose 9% to just above 1 million. This brought a promising 6-week decline in new cases to an end, with more than half of our region seeing increasing numbers of new infections. We are seeing a resurgence in Central and Eastern Europe. New cases are also on the rise in several Western European countries where rates were already high. Continued strain on our hospitals and health workers is being met with acts of medical solidarity between European neighbours. Nonetheless, over a year into the pandemic, our health systems should not be in this situation. We need to get back to the basics. The high rates of transmission and rapid spread of variants of concern across the region requires, first, increased vigilance for variants that pose a threat of increased transmissibility or severity. Second, improved testing and isolation of cases, tracing and quarantining contacts, as well as care. Third, stronger focus on prevention and control of other diseases. Fourth, more effort to re-engage communities and counter pandemic fatigue. Fifth, coherent, gradual and evidence-driven reopening of societies within and between countries when timely, and an accelerated rollout of vaccines. The variant of concern B117, initially identified in the UK, has been reported in 43 of 53 countries in the region. The B1351 identified in South Africa in 26 countries, and the P1 variant identified in Brazil, Japan in 15. We need to suppress the spread of the virus everywhere, using what we know works. Vaccination is already saving lives, with hospitalization and deaths in most at-risk groups declining significantly. But vaccinating every population group will take time. A total of 45 countries have started vaccinations in the European region. 1.9% of the population in 40 countries and 24.5% of health workers in 20 countries have received their completed vaccination series against COVID-19. On Monday, it is International Women's Day, and I want to take this opportunity to shine a spotlight on issues that affect women and one of the biggest employment sectors of women globally and regionally, namely the health and social care workforce. When the pandemic hit, not a single country in this region had achieved gender equality, not one. COVID-19 has since aggravated and shone a light on underlying structural gender inequalities. We have long known that emergencies have a disproportionate effect on women's health, and COVID-19 is no exception, where confirmed cases are more common in females and young adults. The face of that frontline health worker we so often talk about is mostly the face of a woman, more than 7 out of 10 global health and health facility service workers are women. In this region, 84% of nurses and 53% of physicians are women. Health workers account for 8% of global COVID-19 cases, and the risk they run of getting infected is more than triple the risk of most of us, the ones they are trying to protect. 5 weeks ago, out of the 1.3 million health workers that had been infected with COVID-19, 68% were women. We must do everything in our means to protect our frontline. It is fundamental, an obligation of every government, to assure vaccination of the health and social workforce. Therefore, I have 3 key messages. Firstly, to diminish the severe socio-economic impact of COVID-19 on women, their economic participation needs to increase and we need to address the pay gap. We do that through investing in health and social care jobs with fair pay, working conditions and recognition. In non-pandemic times, women perform 3 times more unpaid care and domestic work than men. Containment measures have exacerbated that imbalance, school closures being a case in point. Women are more often responsible for homeschooling than men, and with less childcare available, the demand for unpaid childcare has fallen primarily on women, constraining their ability to take on paid work. And it is still women that are disproportionately responsible for the bulk of domestic tasks and taking care of children and the elderly. In the health workforce, women are clustered into lower status jobs and worse paid positions. The gender pay gap in the health sector is higher than in other sectors, or 25%, which is unacceptable. Secondly, we should collectively ensure that women taking an increasing part in national, regional, local decision-making on COVID-19 prevention and control. It is for good reasons that the theme for International Women's Day on March 8 next week is Women in Leadership, Achieving an Equal Future in a COVID-19 World. Because global health has for all too long been reflected in the fact that women make up 70% of the health workforce but hold only 25% of senior roles. Women remain largely absent from national or global decision-making on the pandemic response. These gaps in leadership are driven by stereotypes, discrimination, and power imbalances. Some women are further disadvantaged on the basis of race or socio-economic class. And my third message today, we need enhanced social support, prevention, early detection and treatment for women at risk of domestic violence. We must also address the mental health impact of the virus and prevent health worker burnout. Across the region, reports of violence against women have seen a dramatic increase. Countless women are forced to lock down at home with their abusers. While the risk of violence has grown, reports show that their access to services is being disrupted. Some domestic shelters are full or have been repurposed or closed. First responders for women are overwhelmed. Women also experience greater psychological distress associated to COVID-19 than men. 2020 data from an Austrian helpline shows that 68% of callers were female and that women tested worse than men on all mental health parameters. If you are a health professional, you are at a great risk of acquiring trauma, stress-related disorders and depression. Studies show that between 20 to 70% of the health workforce is struggling with mental health issues. The greatest concerns are fear of becoming infected with the virus and of the unknown. The financial resources and operational capacity of support services need to be there also and especially during lockdowns. None of this can be ignored, and all of this can be changed. Because when systems are shaking to their core, There is an opportunity for rethinking and building better societies, and we owe it ourselves to grasp it. This is not only about rectifying long-standing gender inequalities. This is about women as health leaders and gendered responses to crisis. It is about equality and women's protection needs at the heart of every response. It is about changing, righting wrongs, outside and inside of hospital walls for the greater good. Global health should be led and delivered by us all. I wish you a happy International Women's Day on Monday. Thank you.
Thank you very much, Dr. Kluge, for a very interesting statement. The journalist will publish the text of the statement as usual on our website. It will appear in about an hour. But if you need it faster, just please drop us an email to the email addresses mentioned in the media invitation. So now we are going to the questions, and let me remind you that the questions can be raised only via Zoom and by just pressing the raised hand button. And please make sure that you unmute your mute when you are connected. Let me first start with the questions received in advance, and I want to thank very much the journalists who took their time to do it. So the first question is from Oskar Gorzinski from the Polish press agency, and Oskar sent the following question. In recent weeks, we have seen a lot of new data about the efficacy of one shot of Pfizer and AstraZeneca vaccines, and it seems to support the policy of delaying the second shot by a number of weeks. Should more countries follow this approach? Also, should people who already have had COVID receive one dose as they are doing in France? And I would like to address this question to Dr. Siddhartha Datta. Please, Dr. Datta.
Thank you so much, and I hope you hear me. Thank you, Oscar, for that question. So let me try to answer your question in two different halves. The first half is the initial recommendation from WHO on the number of doses for both Pfizer and AstraZeneca and Moderna vaccines were based on the clinical trials data that was shared by these vaccine manufacturers, and also including the safety efficacy of the clinical trial data that was submitted. The review of these information by the independent experts led up to the conclusion and recommendation of the 2 doses of these vaccines. However, it is extremely important that these recommendations are reviewed based on the local and the recent evidences that are being generated. The recent data on the Pfizer and AstraZeneca vaccines are encouraging, and I think this will lead us to the review of the earlier recommendations being made. Having said that, the efficacy of one dose of Pfizer and AstraZeneca vaccine is known, but I think the use of 2 doses of the vaccines as it still remains in its current form. The delay of the second dose of vaccines was addressed by WHO and the Strategic Advisory Group of Experts for Pfizer and AstraZeneca vaccine. Those recommendations also stand still. As you would remember, the Pfizer recommendation, which was made by Strategic Advisory Group, has indicated that the second dose could be delayed up to 12 weeks period. The countries, and again, the recommendation of whether people who have already had COVID was also summarized by WHO and the Strategic Advisory Group in their recommendations on the vaccine-specific product. Given that there were insufficient evidence at that point of time containing to the strength and the duration of immunity following the SARS-CoV-2 infection, it was recommended by WHO and SAGE that the people who have been tested positive could be delayed the dose within 6 months of the SARS-CoV-2 infection within the context of limited vaccine volume availability and the country's can make the decision programmatically while considering the recommendations for each of the vaccine products. Thank you.
Thank you very much, Dr. Datta. Thank you for the comprehensive response, but I would like to add another questions on the vaccines here, just to continue with the subject. The question is from Layal Liverpool, from New Scientist in the UK. She's asking, to what extent is skepticism about the Oxford AstraZeneca COVID-19 vaccine undermining the fight against COVID-19 in the European Union, and what should be done to address this issue? And I would like briefly to ask Dr. Kluge and Dr. Datta to explain, to speak about this. Please, Dr. Kluge, if you can start.
Thank you. I think we definitely acknowledge that the narrative of the vaccines by times has been a little bit confusing, but this is science. It's an iterative process. So as Dr. Datta already pointed out, there are processes in place. The SAGE, so it's a WHO Global Advisory Group of independent experts which is looking at those issues. There is also the WHO Department on Pre-Qualification and Emergency Use Listing who looks at those issues. So any vaccine, independent of the origin of the country, is being looked at according to principles laid down by WHO on safety, efficacy, and quality. And I think that's something very important because we definitely need to strengthen the trust by the people in science.
Dr. Datta, can you please add if you have anything?
Thank you so much. Yes, I mean, just to add on to what the regional director just mentioned, there are critical elements for any program for a rollout for immunization, as we have seen also in the past. We would consider this skepticism as people's perception and their decision-making process. This should be seen as an health-seeking behavior of the population to make an informed decision. It's extremely critical that there are the elements that we see for any vaccine rollout should also be part of the COVID-19 vaccine rollout. Instilling trust through transparent communication on any decision-making process will be critical. As also Dr. Kluge has mentioned, a robust evidence-informed decision, which WHO always adheres to, is critical that the population understand the similar informed decision process in a country. The other critical part is listening to what the recipients want or their perception. And then finally, to timely respond to the concern. So I think we have seen the demand and acceptance issues in the region also for routine immunization. The measures that WHO Europe has suggested is to through a formative research, understanding what the issues are and tailor the interventions to be made in a country or also within a country, because the factors and the issues would differ. Thank you.
Thank you very much, Dr. Datta. And then I see we have a block of questions from countries. And I can group them in two sections. We have Azerbaijan and Georgia, and I will start with Georgia in order of submission. Ketivan Kardava from TV Imedi Georgia sent her questions, but she will raise it herself. Ketivan, can you hear us?
Yes, can you hear me?
Yes, very well. Go ahead.
Thank you very much. Thank you very much. Good morning, and thank you very much for taking my questions. If I may, I have 2 points. First, about vaccination. We are still waiting in Georgia to start vaccination, as every day counts and every day matters, and we are talking about lives. It's very, very important for us, of course, to receive as soon as it is possible. The main question now in Georgia, where is our vaccine? So we received COVAX allocation plan, but we don't know yet the exact dates. So what is your main message, Dr. Kluge, to Georgian people before vaccination, and when can it start? And the second point about AstraZeneca, I have a question. In Belgium, for example, AstraZeneca can be used for people aged 18 years and over without an upper age limit. And also it is recommended for pregnant women. So what is your recommendation? What can you tell us about it? Thank you very much.
Thank you, Ketevan. I will turn to Dr. Datta to start answering this question, and then we'll add if needed a little bit later. Dr. Datta, can you please help?
Yeah, thank you so much. So for the AstraZeneca vaccine, the recommendation from WHO and the SAGE, which came out, is still valid, and we would still suggest that the current evidence and the recommendation that was made by WHO for people more than 16 years of age still stands valid. However, we understand that countries would make their own programmatic decision based on their review of these evidences, and the recommendation which was made for the pregnant women, because of the high risk of the women for getting SARS-CoV-2, they are and should be included as a part of the vaccination strategy. For the other point, I would request Dr. Kluge to take it. Thank you.
Rather than going to Dr. Kluge, I will ask Dr. Smallwood to say something about the restrictions measures and lifting the restriction measure in Georgia, please.
Sure. Thank you very much. And Ketevan, thanks for your questions. Just to comment a little bit on the situation in Georgia, we've seen really good progress in terms of the bringing down transmission in Georgia following the peak that it saw in late 2020 in November and December, when in fact Georgia had some of the highest incident rates in the whole region, and now is seeing some of the lower incident rates. So this is really good news. There is a gradual reopening of businesses, of schools, of museums, of public places happening in Georgia. And so the message would really be that this should be done cautiously, as the regional director said, based on the evidence on transmission. We do understand that there have been some cases of variants of concern identified in Georgia, which is not unexpected. It will certainly continue to happen. So now is really the time to focus on the basics, to expand testing, to quarantine all contacts, to isolate all suspect cases, and to continue the good work that's been done. Thank you very much.
On the broader question, Ketevan, so I would like to, because you asked me my message to the people of Georgia, the message is, first and foremost, that the Minister of Health, Katerini Tigaradze, and the government have fulfilled all the obligations, because I see that there is a little bit of different messages in the press that Georgia, as a country, as a government, really lived up to all the obligations. But as we see with COVAX, is now kickstarting, is getting speed, but this is an incredibly complicated process. In fact, the first deliveries globally are arriving in other regions, and we hope really, and we're confident that the coming weeks, this will be the same in our region. There was a telephone conference between the Prime Minister of Georgia and the Director General of our organization, Dr. Tedros, the end of last week on this matter. And even today we were communicating with WHO Geneva and with UNICEF to see about the delivery date, because the purchase orders have been set already. So the message to the people is to adhere to the public health and social measures, and that both their government, the COVAX, and particularly WHO, with UNICEF, are really working around the clock to get the vaccine as soon as possible in the country.
Thank you all. I think we will cover the Georgian part. Now we're going to Azerbaijan, and we have two questions. First, and I'll read them by order of submission, from Ms. Zumrud Pashkin, the correspondent of the Austrian press agency in Azerbaijan. And Ms. Zumrud is asking, in the recent letter from COVAX, it has been stated that COVAX will not be able to provide Azerbaijan with COVID-19 vaccines in the near future. We would like to ask about this reason for this delay. Is there any timetable of delivery of the vaccine? And if there is, with COVID vaccine, and how, and if there is, which COVID vaccine and how many doses will be sent to Azerbaijan? The same questions come from Lachin Sultanova from the Azerbaijan state news agency Azertak. I will, Ms. Sultanova, I'll skip the first long part, the introductory part, and I'll just go straight to your question, which is almost similar. We would like to know the reason why the delay of over 500,000 doses of AstraZeneca Oxford vaccines to be delivered to Azerbaijan as part of the COVAX initiative at the end of February, and also the date when the new vaccine arrived in Azerbaijan. Dr. Datta, I think this question is for you.
Thank you so much. So, in terms of the AstraZeneca vaccine, which will be, which has been allocated to Azerbaijan, based on the press release that came from COVAX day before yesterday, Azerbaijan will receive 432,000 doses of AstraZeneca vaccine, and the allocation has been published, and they will be receiving sometime very soon. We just have to also understand here that the allocation of allocation of a vaccine and the supply of the vaccine has to fit in the context of the delivery of the vaccine using the aircrafts. That has also need to be factored in terms of the delivery date of the vaccine when it reaches the country. The other part, which is also important, is, as we have earlier mentioned, the demand for the vaccine, for which are part of the participating economies in the COVAX, and the amount of volume is not similar. So there is a process wherein there is an allocation of a particular dose of the vaccine is happening. This is the equitable and a fair allocation of the vaccines that is happening across all the countries. So as part of the earlier comment on why there has been a delay in the delivery of the vaccines, which is related to the Pfizer, we do understand that Azerbaijan did express their interest in terms of allocation of the Pfizer vaccine, but that was limited. However, the commitments and the requirements of Pfizer, the additional requirement that has been put together, and that did not allow the Azerbaijan to get into that list of the original 18 countries. Thank you.
Thank you. And the final question submitted in advance from John Garantis inside Story Greece. Many experts suggest that behind the current health crisis, there is an ongoing epidemic of mental illness that will get much worse after the pandemic. Do you believe that European health systems are ready to deal with this crisis? Do you suggest any policies and certain measures that governments should consider in order to tackle this problem? I'm looking at Dr. Kluge. Can you please help with the answer?
Yes, thank you, John. This is, frankly speaking, I would say my main concern. So we're concerned, obviously, about the pandemic fatigue by the people towards the public health measures, which we understand, but it's very, very important as we're seeing a plateauing of the cases. And the other big concern is, as you mentioned, mental health. I would call it even a parallel pandemic. That's why we have convened the technical advisory group to look at the impact of COVID-19 on mental health, and not at least for adolescent and younger people. And I understand that the question was from Greece, so I would like to congratulate here the minister, and particularly Deputy Minister Madame Rapti, because we are now working together on a reform of the mental health services in Greece linked to the primary health care, which can be an example for all the countries in the WHO European region. What needs to be done? It's a big challenge, because we see that during lockdowns, the usual mechanisms of social support are often closed as well. So point number one is everyone to reach out to everyone. Look what happened with your neighbor in your community. And we have seen a lot of solidarities on that one. Number two, where possible, to take advantage of digital means of providing mental health services, prevention and care, but ultimately it's a collective responsibility. Thank you.
Thank you, Dr. Kluge. And we are going to the questions online. Let me start with Jamie Keaton from Associated Press. Jamie, can you please connect?
Thank you very much. Can you hear me?
Yes, Jamie. Yes, thank you.
Dr. Kluge, so nice to see you. Katie, nice to see you. Just a couple of quick questions. One is, I'd like to just drill down on the variants, if I could, a little bit. Particularly, you mentioned the number of countries that are noticing both types, both of the major types. Could you just tell us a little bit, two things? One is, how much is that driving transmission across the continent, across the region? And what are you seeing notably about under 18 people, younger people that are contracting? And then if I could just sneak in a second question, the EMA, the European Medicines Agency, has just announced a rolling review of the Sputnik V vaccine, which of course has been met with some skepticism in terms of the hasty rollout initially. Could you just give us some comment about that, about the importance of that, and possibly dispelling some of that skepticism? Thank you so much.
Yes, I think these questions are almost for all our panelists. So let's start with Dr. Kluge, the first part of the question.
Yes, good to have you also on connected, Jamie. So on the first point, yes, increase in transmissibility, like the variant which was identified first in the UK, up to 50% more. So that's why health systems which were struggling before are even struggling more now. But there is also the good news. I was mentioning that we see, particularly from countries like UK, Israel, which are scaling up fast vaccination, that there is a decrease, particularly in the more vulnerable groups, like the elderly, that the hospitalization rates, the ICU admissions are going down. So it's really, again, we're back at a tipping point on that one, that we have to hold the fort and to be very vigilant. So are we concerned? We are very concerned, but we also have seen it's possible with the same strategy to contain the variants, and the same for vaccination strategy, that if ever the vaccine would have to be adapted, it does not necessarily mean that we have to re-engineer a whole new technology. On underbelow 18 years, I will kindly ask my colleague Dr. Smallwood to say some points. And then on the EMA, indeed, we believe this is a good news. You know, I have been telling this before, that the Russian Federation does have a robust and proven past of vaccine development, manufacturing, uptake. They had a major role in the fight against polio and yellow fever, among other ones. But we are always very consistent, independent of the country of origin. The same criteria go for quality, safety, and efficacy. And we desperately need, Jamie, to enlarge our portfolio of vaccines. So I see this as a very welcome development.
Thank you. Dr. Smallwood, please.
Thank you. Maybe, Jamie, I can expand a little bit on the variants of concern. So, as you know, in the European region, we're referring to the 3 variants of concern. B117, first identified in the United Kingdom back in December, that has clearly demonstrated higher transmissibility, has increasing understanding about potential increased severity from data that we've had from the UK, but also from Denmark. And the question is, what does that mean? This is the variant that is spreading at a widespread level across the European region, as the regional director said, in 43 countries. But we have significant community transmission in at least 26, 27 countries across the European region. And this is being picked up in additional cases as time goes on. In reality, what this means is that with the same control measures in place, the attack rates will be more significant, and that translates into the reproductive number. And the reproduction number will be, if, for example, it's 1 or sitting just below 1 with the measures in place for other variants, it may increase to 1.5 in the presence of this particular variant of concern. So that has a very immediate implication in terms of what additional adherence to the existing measures needs to be put in place, and potentially new measures. Now, when it comes to the under 18s, we have seen a number of countries over the past weeks, and we saw this also with the emergence of the variant of concern in the UK in December last year, report increased infections in under 18 age groups. We do not think that at the moment this is associated with the variant of concern in particular, but what this does reflect is that in these communities, it is those younger age groups, the ones that may still be going into school, that may be picking up these infections and may be somehow the locus of spread in communities. But it's very much part of a community transmission dynamic. And we did see in the UK last year that once the measures were adjusted, that there was a revert to type in terms of community transmission across all age groups in the same way that we've seen for other variants of concern. So I think I'll just stop there, but just to highlight that we are also seeing the B1351 variant of concern spread in the community across Europe to a less extent than the B117, but it is there, and we're monitoring it very, very closely across 26 countries. And then the P1 variant of concern, which was referred to also in the opening remarks by the regional director, we've seen in 15 countries. The good news is that at the moment, most of these cases are associated with international travellers, and we're not seeing widespread community transmission associated with that variant of concern.
Thank you, both of you. I think we have answered the questions well, so we can move to the next one. David Williams from Xinhua News Agency. David, can you please unmute yourself?
Yes, thank you. Could Dr. Kluge explain the WHO's position on the so-called corona passports that some EU countries are mulling over in the region?
Sure, David. It's indeed a very topical issue. So WHO does not recommend passports, but I also believe that, so as we see already, somehow it may be unavoidable. And that's why we are assessing the feasibility and desirability of such a requirement, taking into account what I call some caveats. First of all, from a scientific point of view, how long does a vaccine give immunity? This is not so clear yet, and it may seem a bit contradictory, but if you get a vaccine, it protects you, the person who got the vaccine, but not stops necessarily the transmission from that vaccinated person to someone else. So it's not a watertight thing. The overarching concern, of course, is the access to the vaccines, whether we are going to exacerbate inequalities. And that has also, of course, some ethical and legal issues. What WHO is taking forward is a smart vaccination consortium. So it's on the digital certification, because that's important that whoever is vaccinated, that there is a document there, just like we had for the yellow fever. In any case, if countries go forward, what is needed is, number one, coherence, and number two, sufficient coverage. Otherwise, this will not work. But you know very well, right, David, that WHO follows the international health regulations when it comes to travel and trade. So in that sense, we see these discussions ongoing. It's not recommended by WHO, the passport itself. The certificate, of course, yes. And there are a number of very important considerations which need to be taken into account.
Thank you very much, Dr. Kluge. And we go to Gunilla von Hall from Svenska Dagbladet. Gunilla, can you please unmute yourself?
Can you hear me?
Very well, go ahead.
Okay, thank you. I have a question on the vaccines. More and more countries in Europe are frustrated because it's going quite slowly, the vaccinations, and they are searching other solutions and want to go outside the EU to buy vaccines. For example, Denmark and Austria, they want to cooperate with Israel to buy vaccine doses. In Sweden, it's a similar debate. What do you think about this? I want to ask Dr. Kluge, do you think it is a reasonable way of acting? Should it be encouraged? Do you see any risks with this, that, for example, it would affect poorer countries' chances to get a vaccine? Thank you so much.
Thank you, Gunilla. Dr. Kluge, please.
So, Gunilla, we are advocating and calling upon countries to support the COVAX mechanism. The COVAX mechanism is the only global mechanism to equalize access to vaccines between countries. So what we would like to avoid, obviously, that any bilateral deals are hurting or a setback to the COVAX facility, which is starting to deliver all over the world. So that's number one. Number two, of course, we understand that, I always say, international solidarity does not contradict national responsibility. It are two sides of the same coin, because political leaders are elected to take care of the people in their particular country. But what we would like to avoid is that countries hold back for international solidarity until 70% of their population is being vaccinated. So what we stand for is that healthcare workers, vulnerable people, to be vaccinated as a matter of priority in all countries. So I would not see this necessarily as a breach of solidarity. We shouldn't forget that this is the largest pandemic immunization effort in history, that it usually takes up to 10 years to develop a vaccine. And here we're only 1 year down the road, with an efficacy of most vaccines 92% and above. So these are phenomenal achievements. And of course, there are some teething problems. We acknowledge those. And the need of the hour is to identify those issues, acknowledge them, and collectively work on those.
Thank you, Dr. Kluge. And yes, please, Dr. Small.
If I can just add, Gunilla, because you mentioned the frustration with regards to vaccines, and I think a lot of it may have something to do with the expectation that vaccines are really going to solve this pandemic immediately. And we really have to drill down the message that actually it's not going to happen overnight. With a vaccine at very high efficacy levels, we are still not going to take the heat out of the transmission immediately. We're going to have the populations that are really driving the spread of the virus in our communities continue to do so for some time, because we are not going to have those population groups vaccinated immediately. It is going to take a long time. So we will have to be patient, and we need to use all of the other measures that we have at our disposal to really bring down transmission rates. It's not going to happen right now with any vaccine, even if all the vaccine in the world was available to everybody.
Dr. Doctor, anything to add to this question?
Thank you, Luba. Yes, just one point from my end would be, as we talk about delivery of the vaccine, it is also extremely critical that we understand that the immunization system or the health system in every country is not a similar picture. They all differ widely, and hence the delivery of the vaccine in these countries will also differ. We often run into comparing countries on their vaccine rollout. It's extremely important that we keep that in mind, because the service delivery modality in one country will not be the same in another country. However, the efforts that the countries are making, the sheer scale of this vaccine rollout has to be acknowledged, and we commend them. But as you have heard from the regional director say, that these early teething problems need to be identified quickly, and they have to be addressed. And there is no backturn from that, because the scale of this vaccine rollout is extremely important, but that should be done in considerations with the existing health system and immunization system characteristics of each and every country. Thank you.
Thank you very much. Just a quick reminder, we have about 15 minutes to go. We have 4 questions online and 1 submitted by phone. So we'll go now to Ashwin Barshinjis from Observer Times, India. Ashwin, can you please unmute yourself?
Hello. Yeah, thank you for considering my question. As it is reported that the highest mortality rate of COVID-19 disease occurred due to cytokine storm. My question is, what reports WHO Europe have for the over response of immune system called cytokine storm in COVID-19 patients? Is this considered in vaccine approval for emergency sanction around the Europe? Thank you.
Thank you, Ashwin. And I'm turning to Dr. Smallwood to advise, please.
Thank you, Ashwin, for the question. I will answer it pretty briefly. The cytokine storm that you're referring to is a product of the severe disease associated with COVID-19 that some patients go on to have, which is associated with the way our immune response responds to the presence of the virus in our bodies. The idea of the vaccines that are in development is that they will prevent us from developing severe disease and going on to have hospitalization and coming out with a potentially poor health outcome. Based on the effectiveness studies that we've seen coming out of European countries that are moving ahead with vaccine rollout in those population groups that are more at risk, we're seeing really positive data come in. So this looks very promising, and it looks like the vaccines that we have at our disposal will be preventing severe COVID-19 in those patient groups. Thank you.
Okay, now we have Julia Chapman from Feature Story News. Julia, can you hear us?
I can, thank you very much. I'm speaking to you from Hungary, which is one of a number of European countries that has circumvented EMA approval to order its own vaccines from Russia and China. This is mostly happening in the Central European area, which, as you said, Dr. Kluge, is currently one of the worst affected on the continent. Is this the right approach? Do you have faith in the country's individual regulators to make that decision, or would you prefer that they wait for the green light from the EMA?
Yes, thank you, Julia. Dr. Datta, can you please help?
Thank you, Julia, for your question. So the country, any country is sovereign in their own decision-making process for getting the vaccine in to provide the benefits of this vaccine to their own population. While this sovereign decision lies with the country, it's also extremely important that the national regulatory authority of any country reviews the information related to safety, efficacy, and quality of any vaccine that is being used. While this process is ongoing at the national regulatory authority of any country, WHO, along with the other stringent regulatory authorities, which is the European Medicine Agency, who is one of them, does provide this service to the countries which ascribe themselves or they rely or recognize the decision of WHO and the stringent regulatory authority. So it does not take away the responsibility of any national regulatory authority to review the information from the vaccine manufacturers. The Hungary's National Drug Authority is recognized as a stringent authority by WHO as a part of the European region bloc. So the current decision made by Hungary is in line with their own sovereign decision, plus also ensuring that the population gets access to this vaccine. Thank you.
Thank you, Dr. Datta. And next is Ismir from Ismir Milavic, from N1 Bosnia. Ismir, are you online?
Hi, can you hear me?
Very well, go ahead.
Okay, my question is regarding vaccines, because here in Bosnia and Herzegovina we have quite a controversy because some are claiming that the vaccine which is produced by SII and AstraZeneca is somehow different from the vaccine which was produced by AstraZeneca, and some even claim that those vaccines coming from SII AstraZeneca are for the third world, and the vaccines from AstraZeneca which are coming through COVAX will be for the rest of the world. So can we have some explanation here? Is there any difference between these two vaccines which we will get through COVAX? Thank you.
Thank you, Ismir. And let's start with Dr. Kluge.
Yes, thank you, Esmir. So the vaccines have been included in what we call the WHO emergency use listing, which means that the criteria for safety, efficacy and quality are really met, right? And they're being used in several countries. And last Tuesday, the day before yesterday, Dr. Tedros, WHO Director General, and myself had a call with the political leadership, Presidents Dodik, Komšić, and Zafirović, exactly on ensuring equitable access in the country, Bosnia-Herzegovina. And everyone is really working together, both the country, international community, to get these vaccines, including Pfizer, as soon as possible on the ground as we speak.
Thank you, Dr. Kluge. Dr. Datta, can you please add a little bit on the technical side?
Thank you, Liba. Sure. Thank you, Esmir, for that question. I think it's a very important question, and happy to debunk the myth that you and the listeners may have. As you have heard Dr. Kluge say that WHO has provided emergency use listing for AstraZeneca vaccine that also includes for both the production nodes, as we say, or you can say both the manufacturer, both the Serum Institute of India and Korea. So both these production nodes have been reviewed for the good manufacturing practices, and after that, WHO has provided this EUL for both the vaccine. I think it's not a matter of the country of origin, which will determine who gets what. It's a matter of the availability of the vaccine volume and how quickly these vaccines can be made available to the country, irrespective of their income level, and the country and the population gets the benefit of this vaccine. That has been the main pillar of the principle that COVAX has used, and will remain the same pillar in terms of the allocation of the vaccine, irrespective of its country of origin. Thank you.
Thank you very much, both of you. And we have Stefano Valentino from European Data Journalism Network. Stefano, hello. Can you hear us? Please unmute yourself.
Yeah. Hello. Hi. Can you hear me? Yes.
Very well. Go ahead.
Yeah. So I have a question which relates to the virus replication number. So as I understand, the WHO has reporting standards which should be used by the countries and the regions in the countries, and also understand that there are there's a kind of divergence between data provided by countries, and I guess this makes it difficult for centralized institutions like ECDC or even the WHO to understand and to compare the situation of the spread of the virus across countries. So I would like to know if these reporting standards, as a level of detail, where actually not only the countries but also their sub-regions need to provide data according to specific and common parameters. For example, for the diagnostic system, using either PCR or antigen test or both, or providing data on new cases on the same time frame every day, every week, every month. And for example, hospitalizations variation. For example, when the patients are no longer in intensive care, they should be considered sick patients or deceased patients. I would like to know if there is this level of detail which is required by ECDC and WHO to compare situations and to have the actual risk of spread of the virus in the different countries.
Thank you very much, Stefano. Dr. Smallwood, this is for you.
Thank you very much, Stefano. And this was really predominantly an issue in the early months of the pandemic, when we didn't have really good standardized case definitions, definitions of classifications of deaths due to COVID-19. This mostly has been addressed, and we have a much better harmonized system of data sharing. WHO Europe works very, very closely with our colleagues at the European Centres for Disease Prevention and Control at ECDC. We have a joint information collection platform that we work with, and we update, we adapt, we introduce new metrics when they're needed, such as deployment of vaccinations, such as the presence and prevalence of variants of concern. This database is called TESI. We request all member states to provide weekly information that is standardized in terms of the dates and in terms of the definitions of what information we would like to receive. And we continue to encourage all European countries to provide data into that, to give us a really good, solid evidence base to understand what is going on in different countries, to be able to look at the trends, to compare the trends between the countries, and that includes everything around hospitalizations as well as the epidemiology. So we do have countries, of course, looking at different things in different ways, and we can account for that. We can provide different options for countries to feed in indicators and data for different types of variables, depending on those that they collect at the national level. So we have that flexibility. We have a platform that is in place, that is standardized, that is working really well, and we continue to encourage countries to provide data into that.
Thank you. And we have Nick Cumming-Bruce from New York Times. Nick, thank you for joining. Can you please unmute yourself?
Yeah, cool. Can you hear me? Hello. Yeah, thank you. Can I just come back to variants? I think I may have missed some of your earlier comments, but I just wanted to check. You say the variants are driving transmission at the moment in Central and Eastern Europe. I wonder if you have data on the prevalence of these variants. If you have a number of the new cases in, say, the last week, what percentage of these are any particular variant? And also just to ask, how complete do you think the data is? How much analysis and genome sequencing is going on in Europe to give you complete data on this? Thank you.
Yes, I think we'll start with Dr. Kluge, and then if Dr. Smallwood can add on the technical side. Please go ahead.
Yes, thanks, Nick. First, so yes, the spread of the variants is driving an increase, but not only. Also the opening up of societies when it is not done in a safe and controlled manner. And I think that's what Dr. Smallwood also had mentioned before is a very important element, because the good news in a number of countries is because of the public health measures, the vaccination rollout, and maybe a bit of a seasonality. So the vaccines and the variants are a very important part, but let's not forget about the public health measures. Over to you, Katie.
Yeah, thank you very much, and completely agree with the regional director's comments. It's really the drivers of transmission is a combination of things across the region, including potentially the increased prevalence of the variants of concern, but not limited to that, and adherence, the relaxing of public health measures, and the continued susceptibility across our countries to the virus is certainly a major factor. When it comes to how we're monitoring the spread, particularly of B117. We have weekly meetings with countries to provide quite detailed information, both in terms of the prevalence of that virus among that particular variant among other variants, but also to exchange between countries in the European region on what they find is working, what they're concerned about, how the different competition between the various variants of concern is occurring. And this is an extremely useful way to share information between the countries. Yes, we do have prevalence information coming in, and you would have heard my response to the question before. We ask for countries to provide this data if they have it through our joint ECDC-WHO reporting, weekly reporting platform, TESI. As you know, the sequencing capacities of countries is quite variable across the region, and what we're seeing is a really strong push to increase the capacity of genetic whole genome sequencing in the European region. But luckily, we also have other tools at our disposal to pick up these variants of concern, such as adapted PCR assays that can look for specific variants of concern, and those are in increasing use as well. So we're working with countries to be able to provide access to those, to build capacity around those. And yes, we are tracking the percentage of variants of concern among all cases where we can. And what we've seen, especially in Western Europe and now in Central Europe, is that over time, the percentage of the B117 lineage continues to expand. And as it expands, its capacity to affect the shape of the epidemic curve changes. It's not to say that it's driving transmission, but it's to say that its impact on the overall epidemic curve in the country gets greater and greater. And that's coming to the forefront when those variants, particularly B117, is seen as a dominant circulating strain. And that's what we've been seeing now in several of the countries in the region.
Nick,
so, sorry, just to be clear then, does B117 account for the majority of new cases?
In several countries, yes, such as in the UK, in Denmark. Now we're seeing the same occurring in countries like Germany, where it's approaching 50% and it will be exceeding it. So week on week, that data is changing and we're tracking that information.
Thank you.
Okay, can I ask you a favor? If you have, can I actually use the opportunity and the pleasure of having Isabel Jordi Aguirre at the press briefing, and I would like to conclude with the questions on women and pandemic. Isabel, we don't have a press question. It will be just asking a comment from me. It looked like it's a bad year for women. Dr. Kluge mentioned domestic violence, huge economic disparities, major inequities in access of vaccine and so on. And also the women are the first to take the burden of non-school children. What can be done in very concrete measures at the government, but also at the personal level, to help women through these difficult times? Isabel, can you please?
Thank you, Liu. I think that Dr. Kluge has expressed the priorities that we can have, and I will not dwell into that, but I would like to highlight one issue that relates to the last part of the conversation, and it is the part of the data. I think that the Women's Day is on leadership, and the first step to make women part of that co-decision and leadership is making women visible. And right now, although there are efforts, and Dr. Smallwood has referred to the data that we are asking from countries, at this point in time, we do not have sex disaggregated data systematically collected on infection, on the impact, the short and long-term impact of COVID or in the vaccine. So since the time is out and many of the issues have been referred by Dr. Kluge clearly on the statement, I would like just to end up with this note for a call for the systematic collection and use of sex disaggregated data that's allowed to understand what it is, the differential impact of men and women, and why women may have such a bigger burden in terms of mental health or impact of the COVID-19, but also on the treatment and the vaccine. I think that it is important to make that call, particularly when the press is here, because there is also responsibility on accountability and asking for that sex disaggregated data and understanding the differential impact. So I don't want to take more time, but I think that it is important to highlight at the end of such an interesting
Very
session.
much appreciated, Isabel. Thank you so much. And that basically concludes our today's briefing, and thank you all for joining us. And before we close, the video of this press briefing will be posted on our YouTube channel. And if you need it, it will take probably around 1.5 hours. If you need it earlier, please let us know. So have a good day and stay healthy. Goodbye.